Okay, so today's topic is about assessment and treatment of food selectivity, and this is based on the presentation of Jessica Juanico that I attended at the Tech Traba 2024 conference. Before I start presenting, I would like to ask, what are your experiences? Do you have any experience with any cases and an intervention that you tried, success and difficulties, and did you collaborate with anybody?
Hmm. It, oh, I had a kid like long time ago
Mm-hmm,
that who chewed like fruit, who chewed
mm-hmm,
fruit for a couple of times and then spit it back out, and then had picked a new one, chew and then spit it out. So at that time, we didn't consider all the ethical guidelines that we have right now. It was a
mm-hmm,
bit more loose. So back then, what we did was like, because the kid had to experience that having the whole fruit itself and
mm-hmm,
finishing it was a reinforcing experience. We gave it back because we also told the parents, it's since it was him who spit it out, he can just have it back in again. And then
mm-hmm.
if he chewed it and then he swallowed it, we kind of gave him a lot of reinforcement, and then after that he was okay. We don't know what exactly was the thing that made him spit it out again. But after the reinforcing experience,
Mm.
it was dealt with quite fast.
Oh, okay. Yeah.
Yeah.
Amna, did you have any?
Yeah,
Did you collaborate? Did you collaborate with anybody in your case, GM?
I did not collaborate, but one case I remember that was um, kind of successful was with a child who we did a systematic desensitization with. We introduced apples and cucumbers,
Mm-hmm.
and we did the thing where like we selected steps, for example, just tolerating the presence of a tiny piece of cucumber or an apple, and then like he had to touch it, put it next to his mouth, lick it, put it in his mouth, take it out again, and then chew it, spit it out, and then finally chew it and swallow it. And he did meet the criteria and master the program. But then I don't think he generalized it to in home. I think that he was starting to eat cucumbers and apples a little bit every now and then, but um, like he dropped out, and I don't know if he continued to eat them or not. So that's where the success might have not
And
really
the
translated
difficulty.
to real life. Yeah.
Yeah, yeah. So he was just eating a little bit during session.
Yeah.
Did you do any extinction procedure?
Oh yeah, escape extinction. Because we would keep presenting it until he would eat it.
How long did it take?
Like you mean in terms of weeks?
Uh-huh.
Or I can't remember, it was years ago. But it wasn't like the progress was quite good. It wasn't
Mm-hmm.
slow. Like he was moving through the phases pretty quickly because like after he would meet the criteria, he would get the iPad and he loved the iPad. So like
Mm-hmm.
he was motivated enough to follow through.
Yeah.
And yeah, so it was successful in that sense. But I don't know if he just did not enjoy the foods genuinely. So in like under normal life circumstances, he wasn't very motivated to consume it.
Mm. Okay. Did you have any chance to collaborate with anyone? Both of you,
Um,
and
we do have a speech therapist like
okay.
that we collaborate with, and I don't remember a case where we needed to. Oh yes, actually I do remember. We have a client who has weak um, oral motor oral movements, and like
Mm-hmm.
he struggles with like chewing crunchy food like carrots, that sort of thing. I did consult with a speech therapist for like some
Okay.
exercises to strengthen his
Oh, okay.
jaw, but I don't know. Like it was just a brief conversation, but like I did not bring her to observe the client or anything.
Mm, okay.
Yeah.
Okay. All right. Uh, so pediatric feeding disorder. The definition is a dysfunctional eating in childhood. It is identified when child fails to maintain healthy weight and growth. And it's like you said, Gian, earlier in our discussion, it is prevalent in children. It's about 25% of children who are typically developing. And with those with intellectual disabilities, it's about 30 to 33 to a whopping 80%. So it's even more prevalent for the population that we see. And this ranges from food refusal, so non-acceptance of any food, to food selectivity, where they are limited to eating only a certain type of texture or a certain type of food. Okay. As you know, food selectivity is pretty risky. It could lead to a nutritional deficiency as well as challenging behavior and increased parental stress because parents are worried. Challenging behavior develop because food is considered a threat to them. Okay, and the development of food selectivity, uh, it could be a lack of skills and repertoire. Like you said, the speech language pathologist was working on chewing, swallowing issues. And then it could also be medical, gastrophageal reflux, food allergies, constipation, and these all create aversive feeding experiences, as well as environmental, because caregiver would respond to shape and maintain these feeding problems. So what's really important in treating food selectivity is the assessment. So apparently you need to have an assessment to determine how to best, why food selectivity happened, and then how to best treat food selectivity. And ideally, it should be an interdisciplinary team approach. Physicians need to give their medical clearance. OT and FLP need to do some follow studies. Registered dietitian, and then a DCBA or a psychologist to help with the steps. And then the assessment, there are two types of assessment. We need to do an antecedent assessment. The purpose is to identify the type of feeding problem, like the type of food, antecedent conditions, as well as the consequence assessment. And the purpose is to identify the maintaining condition. The antecedent assessment is to identify the type of food selectivity and identify the foods individual will or will not accept. And then for the consequent assessment, it actually looks pretty similar to an essay. So any guess about usually the result of the consequence assessment? I think
It's escape extinction, right?
yeah.
Yeah.
Alone or combination.
Mm.
Yeah. So the behavior treatments are shown to be very effective. So there are lots lots of what do you call it? Studies that shows it's very effective. And several treatments that are done are high probability sequence. So like 3 scoops of high preferred food and then 1 time low preferred, or simultaneous presentation, high and low preferred food in the same spoon, and later make the preferred food smaller and smaller, and the non-preferred food bigger and bigger. Or you can also have condiment and dressing. For example, carrot. You can have, Americans love ranch, right? And so they put a ranch with everything. So maybe ranch dressing with everything. So a tiny bit of carrot with a spoonful of ranch, and then making the ranch smaller and smaller. I mean, lesser and lesser in quantity. And then also fading. So you systematically increase the size of the bite or the number of bites required before the delivery of reinforcer. And then there's the non-contingent reinforcer, the delivery of something for free. And this may reduce the aversiveness of mealtime and reduce challenge behavior. And then there's the differential reinforcer, a DRA, sequential presentation using a first then. So the delivery of high preferred food or tangible contingent on acceptance of non-preferred food. That sounded like something both of you have done. And then the last one is escape extinction. Usually it's included in the treatment to escape, to prevent the escape from the situation. So escape from aversive situation are presented. Are presented. Sorry, escape from aversive situation is prevented. They did this twice. Usually, the literature shows this two ways. The first one is using physical guidance, where there's the therapist presses the mandibular joint like this, the open mouth, and then number two, the non-removal of spoon, because the non-removal of spoon is less intrusive. This is usually the preferred method in escape extinction. So the spoon is placed on the mouth and it goes wherever the kid goes. Okay. And then there was a case study that was mentioned using extinction, non-removal of spoon. The boy was 2-year-old boy with ASD, and the context was an early intensive behavior intervention classroom. The dependent variable is the acceptance and the refusal of food, and then the response measurement in terms of frequency, percent of trial. So they did an assessment. The baseline was blended baby food. So the kid could eat blended baby food, and they are controlling for taste, equal, how the food is presented, and last one is texture. Um, and so for the taste, it's they differentiate between fruit, vegetable, meal, yogurt, the vehicle, and the texture is held constant. Whereas for when they're trying to assess for vehicle, they use a medicine dropper to put food in, and then the spoon, regular spoon, toddler cup, and then the taste and texture are held constant. The yogurt, everything is sort of blended, and the kid was shown to accept everything. Um, um, for the taste also, the kid was shown to accept everything. And the last one is texture. So they differentiated between different texture, whereas the vehicle and the taste was held constant, but the texture they tried to see blended, chopped, and then regular. So all type of food was tested with a spoon. And the boy accepted all blended, sometimes chopped, and rarely accepted regular. Okay, so let's look at the graph. So when they did the case assessment, like we see here, he accepted pretty much all types of food. And then for the vehicle, he also pretty much that did not matter. But then we start to see clear differentiation in terms of texture assessment. Blended accepted everything chopped, and then you see a dropped in chop, and then the regular was pretty much did not accept anything. And then they differentiated the texture to see in order to see the order of preference. So chopped vegetables was all right. Okay, chopped fruit, pretty good as well. The chopped meat, that's when it went down considerably. So it turned out that the child has an issue with textured meat. So they did the treatment. They decided on the treatment, which is to fade texture level gradually increase across sessions, and acceptance of food leads to praise and 30-second of spoon removal, and refusal leads to 30-second of spoon removal only. And the fading criteria is 3 consecutive sessions with greater than 90% acceptance. They need um, so, so, so it looks, so the graph looks like this. When you're trying to just face the food, the acceptance went immediately down. Right? And then they went back to baseline. And then okay, so just the blended did not. So just fading in did not work, right? So what they tried to do is to put in extinction. So once they have the extinction, then the meat and vegetable went up again. And then it went on, and it continued until they reached regular, and it went back up. So it was maintained. So they had to do fading as well as extinction to have the treatment be successful. Then this lady, Dr. Juanito, she was wondering if, because there is a huge risk of escape extinction, right? Although as a community, we realize that it's often necessary to increase consumption, and it's backed with a lot of research. However, there's also challenges like extinction bursts, response variability, aggression, emotional responding, and spontaneous recovery, right? So she really wanted to explore the effective procedures in the absence of extinction. So, by manipulating parameters of reinforcer, the type of reinforcer, as well as the magnitude of reinforcer. So she is exploring a new study. So this is a new study that I don't think has been published yet. Is it possible without escape extinction? So the types of reinforcer that she is trying to explore was the reinforcer in isolation, whether it's preferred food or toys or attention. And then in combination, like preferred food and attention, toys and attention, as well as greater magnitude. They get to play with toys longer, bigger pieces of preferred food. Only when it did not work, any of the reinforcer manipulation didn't work, then they are moving into DRA and extinction, which is non-renewable. Okay, so the methods are 8 children, ages 2 to 7. They need to accept some fruits or grains, but not others. For example, meat or veggies, and it was done in the children's classroom. And the DZ was the acceptance, placement of food in mouth within 5 seconds, refusal also within 5 seconds, and expulsion, food larger than P exiting mouth, and the topography of challenging behavior. And the sessions are baseline, which is the acceptance was given brief praise and removal of spoon, and refusal is the removal of spoon. And if there is a challenging behavior happening, then they also remove food, and expulsion, no program consequences. For the DRA, they did baseline plus upon acceptance of food, they get reinforcer, and then they did scheduled fading. So from FR2, switch to FR3. So the results, so there are three patterns of results. So we'll first talk about this guy named Harold. So the preferred reinforcer was a tangible. And as you can see, this is the red is the non-preferred food, and then the blue was, sorry, the red is the preferred food, and the blue, oh, all right. So you can see that the red is the preferred food, and the blue is the non-preferred food. And CS is, if you see a CS, then the type of food that was given was carnitas, HD is hamburger, spaghetti is ST. And all is everything, carnitas, hamburger, as well as spaghetti. As you can see, you know, and in baseline one, there was basically very low acceptance on non-preferred food, then very high acceptance of preferred food. And once they put in DRA with all types of food, we see that there is some increase in the non-preferred food, and only when they presented a tangible, sorry, not sorry, A is for attention, sorry. A is attention, F is food, and then T is the tangible. So only when they presented the child with tangible reinforcer that we see change in the non-preferred food. Unfortunately, they started to like the non-preferred food, and so the baseline was kept high. And so they had to change the type of food from, I think it was or something, and then change it to all types of food lectures, like I guess combined together. And we see that they had experimental control again because the baseline went high for the preferred food and very low for non-preferred food. And then they did the VRA again, and then we see that the acceptance of food started to get high again, and it maintains across with just tangible. And this pattern holds. It's quite typical for 3 out of the 8 participants. And then there was the result for George, and again, the non-preferred food was really, really low, 0 acceptance and very high acceptance of preferred food. And DRA with tangible, no, it didn't work, right? DRA with food, we see a little hike here and then 0. DRA with attention, there was an atypical hike here, but then it's 0 again. So they had to do a combination of reinforcer, attention and tangible as well as food, and it went up. And they showed some experimental control because it went back down, which was, you know, but it was still inconsistent, and but we did see some variability there in baseline. And then for treatment again, combination, it held. Baseline, it went down. And then for DRA, it held again. So, so for 3 out of 5 participants, like George, this pattern holds. So not only did they need one type of reinforcer, but a combination of these. Then we see the result for the last types of participants, represented by this Valerie. And we see over here that nothing worked, right? You see that high preferred food is very high, but then non-preferred food is very, very low. Attention didn't work, tangible didn't work, food didn't work, combination didn't work, and then magnitude even. They did a combination of highly preferred everything for 2 minutes, not only very short time like all the rest of the kiddos, but high quality for 2 minutes. That still didn't work. And so for these type of kids, finally they implemented the extinction, and we see that the number finally jumped. And we see in the baseline, although it didn't go all the way to zero, but we see that there's huge variability, so you can still see differentiation between treatment as well as baseline. And then when they reinstated the instructional sessions, intervention sessions, sorry, the numbers went up again. And then they faded from FR2 to FR. Okay. Okay, so the result summary is for single reinforcers, only 3 out of the 8 participants. It worked only for 3 of the 8 participants, but 0 for attention below. So it doesn't look like only praise would work. And high quality attention from adults, that didn't work. We need to either have food or a tangible reinforcer, and then combination of reinforcer seems to work for 3 out of 5 of the participants. And combination and increased magnitude worked for 0 out of 2. So it didn't look like increase in magnitude. If the combo didn't work, then increase in magnitude didn't seem to do anything for them. And these are the patients. These are the participants that needed. So the summary of this presentation is that before we do a treatment of food selectivity from a behavioral standpoint, we need to first consult an interdisciplinary team, and then we need to do an assessment. And in the assessment, we need to analyze why does acceptance and refusal occur. Is it the taste? Is it the height? Is it the vehicle? Right? And then we need to increase success of the treatment, we need to match treatment based on the assessment. And it's possible, and it is possible to not do an extinction for the safety and integrity of our clients. Make sure we do frequent preference assessments, and then lastly, escape extinction may be necessary, but make sure that you do all those manipulation of reinforcers before doing it. That's it. Do you guys have any questions before, or maybe first, what do you all think about this study?
That was very thorough. It's very interesting, and the graphs are also very detailed. I mean, it was a little bit difficult to follow, but yeah, really interesting study, and I like your approach.
Yeah, me too. From the last experiment, I hoped that there would be a result that escape extinction would not be needed, and then there would be a better solution. But of course, sometimes it's inevitable to make some results that actually, if they are related to health and like safety of the kids, sometimes like things that might be a bit aversive for the children might be needed for the better sake. So um it was I was hoping for a bit more of a hopeful um result of not using the escape extinction at all, but it's a good approach because it's asking us to use the other things first and then consider it for the last um, thing to use at the end when it doesn't work. So it will give some order of the approach for the therapist too.
Hmm. Yeah. I think yeah, I agree. I also want to go back to this slide. Um, um, okay, yeah. So pediatric feeding disorder, dysfunctional eating in childhood that is identified when child fails to maintain healthy weight and growth. So how do you all I don't know because I've been thinking a lot about whether or not I agree to do um food to the treatment of food selectivity for my clients with so many I think people coming forward neurodivergent people coming forward um uh saying they which that demanded to have more respect I guess towards their choice um it makes me hesitate a little bit, whether to take on this treatment of food selectivity. But the definition sort of helps me, I feel that, if the child really doesn't need it or the client doesn't need it, then, maybe we need to respect whatever their maybe we need to respect their wishes. I don't know. Dysfunctional eating in childhood that is identified when child fails to maintain healthy weight and growth. So, like if the child doesn't have issues with their weight, they are healthy, and then they are growing. Typically, I guess they are not like really, really skinny. Then maybe I say maybe I give a little bit of perspective towards their parents, and maybe it's okay. Maybe maybe not eating broccoli is all right. I don't know. What do you all think about that? How do you decide whether to take on kids with food selectivity? Parents wanting to treat food selectivity in their children.
Yeah, I was actually thinking about it last week. Um, I was running a support group for parents of children with autism. And last week, the topic we
Mm-hmm.
discussed was food selectivity. And so it's been on my mind. And I think that depending on the case, some children might be easier to introduce an intervention and for that intervention to be successful. Whereas with others, if it's very difficult and in case you might have to resort to escape extinction and like use your heaviest tools, then it's worth checking this with me because my husband had to step out. Um, but sorry, 1 second. Here you go. Here you go. Um, yeah, so consulting with a nutritionist or a dietitian or a family doctor to, see if their current diet um, is putting them at risk of any sort. If not, then how necessary is treatment if the plant is challenging and you might have to resort to escape extinction and some form of intervention that might not be the most safe for the clients. So yeah, we have some professionals we can collaborate with and get a second opinion, I guess.
Mm. Yeah, I agree with that too. Yeah. Um, before I I didn't think of like consulting with other people for or collaborating other than the family themselves. But I think it's gonna be very important to actually see if the child is really in danger of the nutrition part. And but what also I would think of is because uh, the autism population also have like can have bad diets that they can only binge on things that they like, and then it's not about them being too skinny um or that part, but they have to worry about their what is it, diabetes and things like that, being obese. Those part is also part of a health part that we should also consider. So if it's risking their health in that part, maybe we could help them in that way. But like Felicia and Amna said, if it's only about like the parents' preference of wanting their child to have some more veggies or other having more courage to try new food, I don't think we can I think we can then tell the parents about our perspective and the like respecting them more in like yeah,
Respecting their
respecting
choice.
them
Yeah.
yeah, respecting their choice.
So I had this discussion with I had this discussion actually with a parent with two autistic children who are already grown up, and they were like really picky eaters, but now they're not picky eaters anymore. Maybe food sensitive. I don't know. I don't know if they're picky because picky sounds, whatever. So they have food selectivity, right? So this parent said that, now look at them, now they eat everything. And I said, how did you do it? It's not based on any studies, totally anecdotal stories. But then when I heard her description, it sounded very conceptually systematic. It makes sense in terms of ABA. And what she did was that so child only eats French fries. Imagine that, right? Like, what nutrition can you get from French fries, right? So what she did was that she had all types of different food just sort of chopped into bite-sized pieces or like finger foods. Oh, where's Amna? Oh, so chopped into small bite-sized pieces, and she just sort of like put it in bowls, and did not present it during mealtime. So during mealtime, the child just eats French fries, right? So zero stress for the parent. And then when the child is playing and the child has several other siblings, she just sort of have the bowls together with the toys. So the kid will take the cucumber, for example, and put it in his mouth. Didn't like it, spit it out. And it was, no reprimand, no nothing. It was just presented non-contingently, right? And meat or whatever, chicken, put it in his mouth, took a chew, like it, whatever. Also, no, I think she said she did give praise for the child. Sorry, Amna. So you got kicked out when I was trying to describe it. So basically, this mom, what she did was she chopped different types of food and put it into small bowls and put it with together with the toys that the kid is playing. And so while the kid is playing, just took, he would be taking one spear of carrot and put it in his mouth. Chew, chew, chew. He didn't like it and spit it out. And then taking one cucumber or whatever, and then took a little bite and then he swallowed it, whatever. But no judgment, no negative emotion that is paired with anything. And this kid only eats French fries growing up. So during mealtime, he was served French fries, no problem, no pressure. And fast forward 10 years later, he eats everything. Um, this
I
is
like
not
that.
based,
So
yeah,
it's just exposure.
it's just, it's non-contingent reinforcement, right? It was just like, no pressure. It's fine. So it's just exposure. And but I think what's really important though, there's no judgment or there's no negative emotion that is paired with refusal of food, and there is not even an instruction to try this uh, aversive or potentially aversive type of food. So there isn't any. It's just unconditioned stimulus, right? And it's paired with happy activities, and it becomes reinforcing for the child. Then I don't know.
Actually,
I really like that.
yeah,
What do you all think?
actually, my university professor had did that experiment. I forgot about it, but
Mm,
as you told me, I remember that we had this experiment, like collaborated with the university with our center. So we did an exposure for we did group exposure, not therapy, but yeah, we did group exposure play with
mm,
vegetables. So at first we presented all the veggies in small sizes and then presented. None of them wanted to have consume it. But
mm,
then we had this play program for about 10 weeks or so. And then it was like gradually exposing. So all the
mm,
therapists did something for them, but using the veggies, they didn't have to touch it. They had to just like see it and then roll it, like just playing with it. And then while they were playing with it, the therapist also gave some reinforcement. I think it was edibles. And then
mm,
as the weeks went by, um like while the first few sessions had all the therapists touch things and then do things, the
mm,
as the session went by, they had to engage more with it. And then
mm,
after 10 weeks, we just did the first, like the baseline, we presented it, and then most of them consumed it. Like, because they were
mm,
getting used to seeing the veggies, and then they were paired with the play, and then
yeah.
also they were given reinforcement for just engaging or just being there. Then
Yeah.
yeah, it made them consume the veggies in the end. Most of them. I think it was over 80%.
Oh, that's really cool. I has the study been published yet?
Yeah, I think it's published.
I think
Uh,
would it be possible to
I think they
maybe
also made like a program book with it.
mm,
Mm.
yeah, I really like that. Yeah. Yeah, so it's just very natural and I think everybody can do that, right?
Mhm.
Mm, just a matter of feeding that after.
Yeah, yeah.
No. Um so I had somebody else also shared. So this person has worked at another ADA clinic, and it was the program was made by another BCBA. But it was a little bit scary. It was really intense. I was really stressed after she was recounting her experience. So what they did was they put the child in a triangular table, so the child could not escape anywhere. So all she did was just sitting in that one place, and I think they tried to get her to eat some salmon, and they did feeding, so a little bit of salmon, and then they increased the size, and the child was really confused, and I think and a lot of FIV, and then somebody has to restrain the child from the back because she was bang her head at the back, and then for like 45 minutes they have the non-removable spoon. Oh my god, that's so intense. And I think I asked if the program was successful, and 10 years later, no. Um, it was the child was still eating, well, not the child anymore, but the person was still eating junk food. It was, and reading was such an immersive experience for her, and um, I think we really need to be careful in our practices to really prevent that from happening, because I think that's somewhat almost inhumane. Um, yeah, yeah, I don't know.
Mhm.
I think this study is important. The study, the one that I presented, is really important to show that we need to, number one, I think we need to have collaboration. Number two, there needs to be a careful assessment to really target what is it that they don't like, and then work very slowly. If they don't like texture, maybe we can start with chopped vegetables or chopped fruit that they like first, and then slowly fading in um, blended meat, and then increase the sizes of of the meat into from small chunks into bigger chunks, um, instead of having this trying to do this escape expectation as like um, um, uh, the number one solution right away, right? Because we really don't want to have meal time to be very aversive, because we have to eat to maintain our nutrition. We have to eat to socialize, right? Yeah,
Yeah,
I
that's
think I think it's I don't know. I think I was like, when I heard about that, I was like, no wonder ABA earned such a bad reputation in the autism world.
mhm.
You know.
Yeah. But I was surprised because you came back after graduating in around 2022, right?
Mhm.
So it hasn't been long since you've attended the university,
Mhm.
and then it changed within 2 years, like to
Yes.
have that flow. Mm.
Yeah. Yeah. So I was really impressed, because I had a friend, and she had ADHD, and she was not comfortable in disclosing her condition, and she also did not get accommodation, even though we are in the special education department. Um, so there is a dichotomy between uh, the theory that we heard, the best practices that we said needed to happen, and what is happening. And so that was, I don't know, came out from that program really sort of disappointed, as well, in terms of like how inclusion is happening. But then I was really happy when I heard Dr. Rajaraman talked about things that the undergrad is now doing. And he really only joined the faculty after I left.
Oh, okay.
Mhm. Yeah, in the fall of 2022. That was already,
Mm.
yeah, I already graduated.
All right. Any last comments or any last questions or anything before we wrap up?
Um, uh, no, I think we just need to, I think just reiterating how interdisciplinary team really work, make sure we have informed decision why we need to do treatment of food selectivity, right? Is it really needed? Because sometimes we need to do a state extinction, and we don't want to do that unless it's absolutely necessary. So to get a check off from the SLP, the swallow study first, and then the okay from the medical, have a medical advice, and then also from the nutritionist, are they missing key nutrients, in their diet? You need to do this treatment, right? and then absolutely doing the assessment. Where does the acceptance and the refusal occur? What is acceptable for the individual? What is not acceptable for the individual? And really carefully target that. And then matching treatment based on assessment and as much as possible, not to extinction, and do reinforcement based. And then frequent assessments, and lastly, also try to look for more technology to see to avoid a state extinction, but only do a state extinction when it's absolutely
Mm-hmm. I have one last question. I don't know if you could give us like the least amount of collaborative team that they could have. Because like thinking realistically, like in Korea, or in my case, like if I had to ask parents to actually
do
consult
all that.
everyone, yeah, I
Yeah.
don't know. It would be difficult for them also to actually go through all of them and then like come up with one solid opinion to do something.
Yeah.
What would be the least amount or the first person to like consult with, that if you could just choose one, would it be just a doctor to consult first, or would it be a nutritionist? Like
I
who
don't
would it be?
know. But such a good question. I was also, when I was listening to that, yeah, good luck doing that in Indonesia, right? Yeah, such a good question. I think I would at least need to have like a written recommendation from the doctor. I think at least I would I would probably do that. That's what I personally would do. This
Mhm.
kid is missing XYZ and really needs to have I don't know, more whatever, and he could not get this supplement from something else. Therefore, please help with this issue of food selectivity. Then I would probably consider.
Yeah,
And
yeah.
I would absolutely recommend doing it through play first, right?
Mhm.
Before doing any structured systematic um, intervention. I
Yeah,
don't
yeah.
know. What would you do?
You mean treatment wise,
Um,
or the question that I had?
yeah, the question that you have, like, what's your hunch?
I think I would have like probably the same um idea as you said, but
Mm,
yeah, like at least consult with with a special doctor who actually knows more about the nutritional part. Like
mhm.
that would be helpful, and also someone who knows more about autism also, maybe it would be better,
Oh,
because like not all
sensory,
doctors.
like some
Yeah.
sensory specialist, maybe,
Uh-huh.
right?
Uh-huh.
Yeah, I like that. Yeah.
Mm.
What
I'm
would you
not,
do, Amna?
yeah, I'm not. Do you have ideas?
No, that was a really good point, the last thing you mentioned about a doctor being specialized, because when I was thinking about my own response to the question, I think I would lean more towards a nutritionist or a dietitian. But yeah, because doctors generally, like, they know a lot about medicine, but like maybe their knowledge about autism or about the diet, it might be more limited. So yeah, even in terms of that, I think seeking the consultation of a doctor who is specialized in autism, um, and knows more than like the average GP, like general practitioner,
Mm-mm.
is something I would consider.
Yeah, yeah,
I would probably then also consult an OT, somebody who knows about sensory.
yeah, yeah. OT is
Um,
also important.
yeah.
Mm-mm.
Maybe, yeah, like you said, maybe somebody who a doctor who is knowledgeable about nutrition and worked a lot with kids with autism. And then maybe if it's available, a note to who knows about sensory sensitivity.
Yeah, the more they know about all of these things, it would be better. But yeah, if we could just consult one, I think the people we mentioned might be okay to start consulting our clients, right?
Yeah.
Mm-mm. Okay. Thank you, Felicia, for the interesting and newest, maybe the latest.
Have you guys gone to